Welcome, everybody. Such the buzz, right? It's Friday afternoon, and we've got someone really special with us here in Lexington, Kentucky. So welcome, and thank each and every one of you for joining us today. As many of you know, I'm Dr. Janie Heath, the Dean of the College of Nursing at the University of Kentucky. We are thrilled to see such a wonderful outpour of support for our Nursing Leadership Lecture Series. In particular, we would like to thank some of our partners and colleagues that we have with us here today. Of course, our UK HealthCare colleagues, nurse leaders, our faculty, students, alumni. We have several of our faculty emeriti, friends from Baptist Hospital, Veterans Administration Medical Center, Kentucky One, Norton Healthcare, Frontier Nursing University, Berea College, Galen College, and Kentucky Nurses Association. Welcome to the Big Blue Nation. I don't think there's anybody else that we haven't had here in this audience for this special day. So on behalf of my partner, Dr. Colleen Schwartz, Chief Nurse of UK HealthCare, and of course, UK College of Nursing, it is my distinct pleasure to introduce to you Dr. Pam Cipriano, the 35th President of the American Nurses Association, the nation's largest nurses organization representing the interest of our nation's 3.4 million RNs. Go nursing! Dr. Cipriano has held distinguished executive positions in healthcare systems, academia, and national professional organizations. She was named one of the top 100 people in healthcare and one of the top 25 women in healthcare by Modern Healthcare magazine in 2015. Prior to becoming ANA president, she served as senior director for healthcare management consulting at Galloway Advisory by iVantage and has had faculty and leadership positions at the University of Virginia since 2000, where she currently serves as research associate professor at its School of Nursing. She was currently, and this is how I know Pam, was the chief nurse at the University of Virginia that I had the pleasure of working with. Known nationally as a strong advocate for healthcare quality, Dr. Cipriano has served on a number of boards and committees for high-profile organizations, including the National Quality Forum and Joint Commission. She was the 2010-2011 Distinguished Nurse Scholar in Residence at the Institute of Medicine. A longtime member of ANA, Dr. Cipriano has been active at the national and state level in multiple organizations and fields. In addition to serving 2 terms on the ANA Board of Directors, she was the recipient of the Association's 2008 Distinguished Membership Award for her outstanding contributions to ANA. From 2006 and 2014, she was the inaugural editor-in-chief of the American Nurse Today, the official journal of the American Nurses Association. Dr. Cipriano earned her bachelor's degree in nursing from American University, her master's in physiological nursing from the University of Washington, and her PhD in executive nursing administration from the University of Utah College of Nursing. She was inducted as a fellow of the American Academy of Nursing in 1991. Please help me welcome Dr. Cipriano.
It is truly a pleasure to be with everyone today, and so and you also really can't have a better cheerleader in your court than Dr. Janie Heath. So I am delighted to be with you. And before I start, let me just find out a little bit about who all these great groups are in the audience. So how many of you are students? All right. How many of you are staff nurses? How many of you are other team members in the medical center? Great. And how many of you are in a manager or administrative role? All right. Some of you may raise your hands 2 and 3 times, right? Faculty members? Fabulous. Other community leaders and our KNA leaders? All right, great. Is there anybody I missed? All right, lots of hands and lot of great activities. So I'm very, very pleased and honored to be with you today. One of the things that we all think about is, what is the future going to hold? You know, why do we work this hard? Why do we do the things that we do? We're kind of thinking about what's over there at the end of the rainbow. Because if we weren't optimistic, if we weren't really focused on the future, the day-to-day work that we do can be pretty tiresome and can be emotionally draining. So we really do have to be thinking about, what is it that we're doing that we think is going to leave not only nursing better off tomorrow, but really the people that we serve and all of healthcare. And nurses really are, in my mind, some of the most productive and most influential individuals really shaping that future. We certainly have the capacity, but we need to be more recognized for what we're doing. So I'm going to talk with you about a number of things that the American Nurses Association is working on and some of the key issues before us. But now, before I get into some of the details, some of you may have seen our new enterprise logo. So we've always had a version of the Florence Nightingale lamp, but we decided it was time to have a more contemporary look and one that pulls together the entities that are primarily part of what we know as ANA, which is our membership association, our foundation, and the American Nurses Credentialing Center. We also have a separate 501c3 subsidiary, which is the American Academy of Nursing, which is an honorific society that is also part of ANA's family. When we think about where we've been with U.S. healthcare, without a doubt, prior to the Affordable Care Act, the passage of Medicare legislation was the most important, most meaningful change that shaped healthcare in this country. So it created the impetus for hospitalization because someone was now paying for it for older individuals. It really came at a time that there was money being put into bricks and mortar, so that many of the hospitals that we know today were actually built around that time, following some of the monies that were made available after World War II. But one of the other things that's been important to us is, if you see this individual right here, that's Jo Eleanor Elliott, now deceased, unfortunately, who was president of the American Nurses Association at the time. She eventually was the Assistant Surgeon General, which at the time was the position that led the Division of Nursing in the Health Resources Services Administration. But she's talking to President Johnson about the passage of the Medicare legislation. What you may not know was that the American Nurses Association was the first professional association to step up and publicly support the Medicare legislation. And our physician colleagues were violently opposed to Medicare. Interestingly enough, when you fast forward decades, you know, we've celebrated the 50th anniversary of Medicare last year, it had become the bread and butter of physician reimbursement, as well as hospital reimbursement. When we think about healthcare reform in our time, because the discussion has gone on through the 70s, where we had voluntary cost containment, through the 80s and 90s, where we saw the implementation of diagnosis-related groups, it is always following the money, always following the money. But as we think about healthcare reform in our professional time now, the Affordable Care Act that was passed in 2010 is the most substantial and significant long-term impact that we will see in healthcare. Undoubtedly, you know, if it took 45 years for one change, and we think about where our Congress is today in terms of not really coming together on making many decisions, the Affordable Care Act is probably where we are. We will see additional regulatory changes. We will see programmatic changes. But ultimately, you know, what we see is that the Affordable Care Act, as we've seen a number of the conditions come into play, and they'll continue to get tweaked, and there'll be additional provisions. And you may not like any of it, and it may not be in line with your political affiliation, but ultimately we know that a lot of good has come from that act. I mean, again, there are some unintended consequences, but we now have some of the most feared situations being addressed, where we have health insurance exchanges. We have young people being able to stay on their parents' insurance to the age of 26. We have preventive health covered as part of a benefit package. We have, you know, more available mental health care. So it has not only created better care and opportunities for access to care of poorer people, it also has created opportunities for nursing. on a small scale, but one that could be built upon. Now, the other person that I would show you is this individual right here. This is Becky Patton, who is a past ANA president of 2 presidents ago. So again, she was intimately involved in the discussions that were going on behind the scenes in the formation of the contents of the Affordable Care Act. So ANA has been at the table, which is a really important place for us to be recognized that, you know, if we're going to have a real role in health policy and shaping healthcare in this country, we have to have the most fruitful connections. And you really can't get much higher than the White House. So we're very pleased about that. Now, one of the other areas that we see that policy is being influenced is at the Supreme Court. So if you haven't had the pleasure of going to the Supreme Court in Washington, D.C., which is building is like right across from the Capitol, there are lots of times where there are demonstrations on the day that a particular case is being heard. And so this was one of the days, one of the last big challenges that was heard in the Supreme Court. There are more, you know, and the Congress keeps wanting to challenge the act, but this was one of the last ones last year. And this has been a byline that ANA has had for a long time. When nurses talk, Washington listens. And the bottom line is we represent a significant portion of the voting public. 1 out of every 100 people in the United States approximately is a registered nurse, but 1 out of about 45, the numbers shifts, but 45 to 50 individuals is a voting member of the public. So nurses actually could have a significant sway if everyone came out and voted. Now, we know that our work is not done in terms of really looking at healthcare reform. All of these challenges continue to affect us in various ways. We've got an aging population. Many of you see that in your day-to-day practice. Whether it's the aging person that wants to stay healthy, which means they're having their joints replaced so they can stay mobile, or they've gotten into trouble with a chronic condition, or they're an older person that has a low income and gets into trouble because they can't fill all their prescriptions or they can't put food on the table. We know that we have a number of serious issues with the aging and sicker population. We also know that as a country, we have not really focused on preventive care. We have, to a lesser degree, in policy that where we've required immunizations for children to be able to go to school, but we haven't done as much in terms of, better not hold that. It's like magic. In terms of saying, you know, it's really important that people get their appropriate screenings that the Preventive Services Task Force has recommended, and those kinds of things. Now, one of the things that's interesting is that as I've had the opportunity to learn a little bit more about global health and how other countries address health, there is a distinct difference. In the United States, we have spent billions of dollars and lots of years trying to cure illnesses after they happen. So we spend an enormous amount dealing with diabetes and heart disease and cancer and kidney diseases and things like that. The numbers are astronomical. The rest of the world calls those non-communicable diseases. And they're really waking up to the fact that it's non-communicable diseases, what we call chronic disease, that is crippling their countries. So it's now really hurting their budgets, their healthcare budgets, and they look at it as bankrupting the society. That if everybody gets sick or everyone is dependent on seeing healthcare providers and taking medications and not feeling well and not being able to have a healthy lifestyle, that's a real burden. So that's being addressed globally, and I think the U.S. is finally going to get some additional pressure by saying, you know, you're one of the wealthiest nations in the world, and look at these terrible problems you have. Not to even mention what we know is, you know, like the neonatal mortality rate, where we rank, you know, much lower than many other countries, including some underdeveloped countries. We also know that as we've tried to shift our health policy to have more primary care over the years, that we haven't really completely made the shift. Yes, we have advanced practice nurses that are providing a lot of primary care, and we did have a push to try to increase the presence of primary care physicians. But for those of you that have been in healthcare for more than 10 years, you know that actually kind of flopped. The push was that everybody would have a primary care provider. They would go through that primary care provider as a gatekeeper so that we would know what kind of care was needed. We would have them being monitored and that everything would be great. Well, it didn't really work. And one of the reasons is, again, the lopsided payments. So much of our health care really is driven by how we pay for care. If you compare physician salaries in the U.S., because they are the primary providers of the kind of care that we think about in primary care, the contrast between specialist salaries and primary care physician salaries is enormous. Again, you probably know much of this. So you could have your average neurosurgeon making more than $1 million a year, and you can have your average primary care physician making maybe $150,000 a year, depending on where you live. In many of the European countries, all of whom have a government-sponsored health plan, in many of those countries, the primary care physicians make more than the specialists. They're all regulated and they're all salaried. So there's very, very different incentives in terms of keeping people healthy and monitoring what they're doing. We know that when Massachusetts implemented their healthcare reform as the precursor to the Affordable Care Act, you heard what happened. You know, all these people now had insurance and they couldn't get it into a primary care provider to be seen. So they've rectified some of that, just as the rest of the country is. And we've seen the advent of primary care medical home or primary care health home, many of those run by advanced practice nurses, the majority of those still run by physicians. So we're starting to address the problem, but probably not at the rate that we need to. And we know we still have very high costs that are unsustainable. So the major goals of the Affordable Care Act, which have also been very helpful to Kentucky, have, again, expanded the insurance coverage for people. Again, the system is not perfect. We know that there are a lot of high deductible plans. They are difficult for people to maneuver, so we know that there are still people that are foregoing care because they don't want to spend out of pocket what that high deductible is. But we continue to see advances in terms of the improvement in quality, an increased focus on wellness, and really trying to move from paying for volume to paying for value. Now, in March of this year, so just a month or so ago, the Foundation for a Healthy Kentucky released data from 2012 that showed that Kentucky's overall uninsured rate dropped by 4.9%. So the uninsured rate from 2012 to 2014 is now 8.7%. And one of the good things is that the lowest income residents in Kentucky were the ones most benefited by this, which again is really important because we want to be able to have people not forego care. We want them to be able to have access to providers and to the bigger health system. So Kentucky is doing better than the overall U.S. uninsured rate, which is still 11.6%. You should all congratulate yourselves for being a state that passed Medicaid expansion. As you know, only about half of the states did. There are some states that are trying to do separate waiver programs and figure out how to do it. But essentially, the Medicaid programs are allowing people who are at low income or no income to be able to get essential care. And it continues to be kind of a fight in a lot of other states. And I know you're reorganizing your insurance marketplace, but you're continuing to offer plans that will either be through the government exchange, which we know that they had major IT problems to begin with, but have been resolved. And so you are providing that access, which is really important. As you know, across the nation, 20 million more people have signed up through the exchanges. So that's really significant. The impact of the Affordable Care Act overall has been, again, more patients have coverage. We are emphasizing the quality of care. Used to be, in most cases, we have paid for quantity. The more tests you do, the more hospital days, the more visits, the more payment. And that has been shifting for quite a while now. And about 40% of payments are quality-based. But that's really the major emphasis. If we incentivize in the right way, we can see the shift in care that we need. Now, nurses aren't really pushing those changes. We are the force behind the scenes. And so we need to become a louder voice in terms of advocating for understanding by the public of how important it is that they look for quality. This was something that I just heard in a discussion last week that was rather disturbing. So let me ask you a question. How many of you believe that more than half of the public looks at quality data before they go to a provider? Well, you're all right. But if someone goes and looks up a provider and finds that they don't have very good quality, but they had a positive experience, they felt that the service that they got was really good, will they then shop based on quality? No. It is what kind of customer service did they experience is a much, much more powerful force in that decision. So it really makes you stand back and say, my God, we're spending millions of dollars to pay people to collect quality data, report quality data, pour over quality data, create these scorecards, and it's not making a difference. One of the most stark examples, I hadn't known this, again, until this conversation, was that when Bill Clinton had open heart surgery in New York, the center that he went to had 10 times the mortality rate of the best performer. Didn't make a decision, or didn't influence the choice. So I think we need to understand that even though we're going to move to pay for quality, we've got some education of the public to do, because we really want them to get the best care possible. We've got new roles, we've got new competencies. Again, I think you're recognizing that the Affordable Care Act came with a little work involved. We also know that the changing landscape of reimbursements has been very difficult for hospitals. One day we hear the inpatient payment system is going to go up, next day we hear it's going to go down, next day we hear, well, they're going to hold off, and the next day it's like, well, we got bundled payments, but then maybe they're going to wait. So it's very unnerving for leadership in hospitals and medical centers in particular to be able to predict what's happening. In the meantime, we saw patient volumes go down when we had the recession. Then we've seen volumes surge. We hadn't been replacing the staff to take care of those patients. So we're caught in a conundrum of trying to figure out, what is this changing healthcare reform landscape doing to us? We continue to see people that come to the emergency department for care. And again, this is really all over the place depending on where you live. So if nurses are going to help drive some of these changes, what is it that we need to do differently? What do we need to learn? And there's a couple things. The first term, you've heard it a million times, big data. Well, it's not so much to understand how does IBM Watson work. I mean, essentially, that's one of the primary engines behind understanding the analysis of data. But what's beginning to demonstrate the most impact is predictive analytics. Now, I'm not sure what we do in the UK Medical Center here. And I'm sure you have a data warehouse and you have lots of people that look at the data. But the more data that we can analyze to look at the trends of what's happening to people, who is going to be at risk for that next cardiac event? Who is going to be that unstable diabetic that's going to end up back in your emergency department? Who is that asthmatic that seems to have great difficulty being controlled? Which children are not able to adhere to a regimen? We have all these data that now can actually predict for us what needs to happen to keep people out of the hospital, to get their care in the right setting, and titrate the amount of care. So big data is really important. However, one of the things that we may not have enough of is the nursing data embedded in our data warehouses. If your electronic health record isn't capturing coded data about what all of our nurses are doing, we don't know whether the nursing care made a difference. We don't know whether the precautionary measures that were taken are preventing falls. We don't know whether the measures that were taken and the bundles that we're using are responsible for preventing hospital-acquired infections. So we need nurses, whether they're chief nursing informatics officers or super users or members of the research, we need to make sure they are embedded in the flow of work to really understand what data are going in and what data need to be pulled out, and working side by side with the teams that are analyzing the big data. The center block there, care coordination, the game changer, is really nursing's sweet spot. One of the things that we know nurses have always had the skill to do, because part of it is taught in school, but also part of the nursing process and how we assimilate and analyze is really thinking longitudinally about what are all the things I need to be doing for this patient? What are the social issues that are impacting care? What are the financial issues? What are the language issues? What are the healing issues? What are the underlying concerns that this patient and family brings to their condition? And we know now that we're not only specifically making positions for nurses who coordinate care, but we're expecting with all of the multiple handoffs that every nurse in that chain of events can communicate and understand the important handoffs and the important steps that every nurse needs to contribute. As we think about the fact that there is a bias toward not having or not be willing to pay for registered nurses in the non-hospital settings, the role that's going to definitely stay in place and only get bigger is that of care coordination. Insurance companies learned long ago a nurse care coordinator, whether they're under the title of a care manager or case manager, is incredibly important because they're all about saving money. We know that the care coordination is really important in meeting the patient's and family's needs and preferences. So pay attention to how you're out there figuring out care coordination within your system. And then the last one on there, rapid information processing. Barely need to mention that. You know you're collecting a ton of data. You know that you are constantly called upon to make sure that you have information at your fingertips, and whether it's aided with artificial intelligence or whatever. I mean, it can be daunting. It is a pretty difficult task on any given day. And we also have, again, this changing landscape of how do we pay for care? How is care delivery organized in the primary care setting or the hospital setting? How do we make sure that we're keeping up with this alphabet soup and that we know what models of care are really going to produce the right results? Well, we don't always know, but we just pay attention to what that next news flash is, whether it's from our nursing association or whether it's from Modern Healthcare magazine, that things are changing and we need to stay on top of it. Now, another moment that happened right around the time just shortly after the Affordable Care Act being passed was the release of the Future of Nursing report by the Institute of Medicine. Now, how many of you at least glanced at some of it or an article about it? Okay, great. And it really wasn't going to escape you. But this is one of the most significant studies that's been done about nursing. I have bookshelves full of paperbacks that I've collected over my career of all kinds of studies that were done. They got produced, they got printed, and they sit on a bookshelf somewhere. Not just mine, but all over the country. This one, however, interestingly, if you don't know this fact already, to this day, now 5.5 years later, continues to be the most downloaded report by the Institute of Medicine all the time. So this report has gotten a lot of attention by those interested in learning about it and those interested who don't like what's in there. Which is always possible. But there are, as you know, there are a number of recommendations that call for more education, that call for greater leadership skill, that call for better data collection, that call for nurses as partners in leading change. And so 5 years after the report was initiated, the Institute of Medicine said, let's see where we are. We're not going to debate the recommendations, but we want to see what we've produced, because the trajectory was that these recommendations would be in place with significant action in 10 years. So at the 5-year look back this past year, they did produce another report. And the good news is that at the halfway mark, we had made a lot of progress, particularly as we look at doctoral preparation. And the goal was to double the number of nurses doctorally prepared. But we have blown that out of the water with the Doctor of Nursing practice programs. One of the other education goals, 80% of all nurses would be baccalaureate prepared by 2020. We're not so good on that one, but we're making progress. And there are, again, some of the other recommendations that are pretty straightforward. Again, deal with workforce, deal with data collection, deal with the other main area that's been the emphasis of all of our state nurses associations in ANA, and that is full practice authority. Really for all nurses, but it's been most critical for advanced practice nurses. So for the 24 states, I think, that still don't have full practice authority, that's been a push. And since the report came out, 4 states actually have changed their laws. So that's an important part of where we're going. I was asked to participate on a panel last summer, kind of giving what I thought was a status report or a report card on where we were with the recommendations. So, I think we've made great progress in reducing barriers to practice, leadership, residency programs. Oh, I forgot that one. But we're really kind of lagging behind on the BSN, even though we'll get closer, but we're not going to get to 80%. We're only at about 51% now. Like I said, we've done well on nurses having doctorates. Lifelong learning, not a problem. Leading change is really part of the whole leadership development, but collection and analysis of interprofessional workforce data is also at a 0 level. The government stopped collecting data in its usual way, and so now we have discrepancies in terms of what the Health Resources Services Administration shows in their data versus what the Department of Labor shows. And so we have real serious issues. Not every state has a workforce center to collect robust data. And so we're really not able to digest and understand what's happening. And I know from what I hear from nurses all around the country that we have significant shortages in a lot of places. The HRSA data would say there are no shortages other than specific geographic areas. The Department of Labor data says by 2022 we'll need 1 million more nurses. So we really need to rationalize what's happening there, and we need to be prepared. So we know that workforce is an issue. Scope of practice, wanting all nurses to practice to the full extent of their education and training. And we're careful not to say licensure because, again, we know in some states the licensure actually is restrictive, particularly for advanced practice. Again, building leadership capacity and certainly improving quality. So we have advocacy for nursing workforce, which is really ultimately, again, about the money. This is the support for Title VIII funding, which is part of the Social Security Act, that has been the bread and butter to support some basic nursing education expenses over the years. So this year in the President's budget, the amount that was put forward to be funded is just a flat rollover from the previous year. The nursing community had asked that it be increased, but unfortunately it wasn't. So in February of 2016, we're seeing $229.5 million, which is really in the federal budget a real drop in the bucket. So we continue to advocate for this. There is a nursing caucus on Capitol Hill, which is not just nurses, but members of Congress who are supportive of nursing who come together to advocate for this funding every year. Just another note on scope of practice barriers. One of the things that again, you've already been more advanced in Kentucky, but we continue to have to bring forward and repeat over and over and over again that there's 20 years of research that shows how significant advanced practice nursing care is. That it not only is equivalent to physician care in terms of outcomes, but there is higher satisfaction, and that there really is no need for supervision by physicians. And of course, we know that there are certain physician groups that have opposed this. And again, it's concerns about encroachment on territory, which again goes back to the money. But two significant papers to be aware of. The National Governors Association did a report that really emphasized how much more the patient satisfaction was in care provided by nurse practitioners in primary care, and that there was no question of the quality being equivalent. And then the Federal Trade Commission did an analysis of the costs of supervision and said this is unnecessary. The quality is the same. Why would we put a system in place to pay for supervision? So those continue to be cornerstones of our arguments in favor of full practice authority. I mentioned the Supreme Court, which has made rulings on the Affordable Care Act, has made rulings on a number of key issues, and one of them, which you may not have heard of, is what's been referred to as the teeth whitening case. Anybody heard of it? Just a couple of hands, probably if you're an advanced practice nurse. And the bottom line was that in North Carolina, hygienists wanted to participate in teeth whitening, and the dentists said, oh, no, that encroaches on our practice. And so they tried to stop hygienists from providing teeth whitening services. Well, the Supreme Court ruled in favor of the hygienists, saying they were very well educated and capable of providing that service. Lots of parallels, as you could imagine, for advanced practice nurses. So that whenever you have a court case that creates a precedent, it's important to pay attention. And we thought this was interesting too. This was a March 18th, 2016 article or blog in the Washington Post that highlighted a couple of the states that have made advances in their Practice Act, particularly West Virginia and Florida just recently. And I don't know when Kentucky got full practice authority with just a small piece of supervision, but it takes years to get this legislation passed in most states, 5, 6, 7, 8 times or more. And so these are real acts of courage on the part of the State Nurses Association, working together usually with their nurse practitioner associations and really finding congressional or state House of Delegates and senators that are supportive. There's a few other scope of practice things that we've been working on. In addition, we're looking at the generic registered nurse scope of practice, so we have a panel that's looking at that. One of the reasons that's really important is that we believe that the role of the registered nurse in primary care is going to expand, needs to expand, so we really need to look at what is that full set of skills and what's the education that we need to match up with that. We still want APRNs to be able to be certifying patients who are covered by Medicare for home care. It's strange that they can be the individual that sets out the plan of care once the individual's admitted to home care, but there's still a glitch that they cannot actually certify for home care. And then we are awaiting any day now in the Veterans Administration, the release of what's called the Nursing Handbook, and we're waiting for it to come out in the Federal Register. But this is a rule change that would equalize NP practice across all the VA systems. So right now, to practice as a registered nurse in the VA, you only need to have a license in a state. So they acknowledge that if you have a basic license, you can practice in any VA. That's not true for advanced practice because we know all the states have different requirements. So the VA has said, we want to be able to define the scope of practice and abilities that we want APRNs to hold within the VA. And we believe there's a fair amount of support because, as you know, the VA has really been under pressure to provide better access and quicker access to care. Now, one of my pet peeves, as I've had a chance to talk with a number of groups already this morning, is making sure that nurses are at the table, that their voice is heard, that we are, again, at the circles where big decisions are being made, whether they're in government, whether they're in our organizations, whether they're in our community or other boards. We need nurses to be representing our voice. Last year, we were successful, ANA, through many of its partners, to have 40 nurses appointed at national levels of all these groups that you see represented here to serve on committees. It is no small feat for two reasons. One is you have to have really quick access to people, their CVs, they have to be willing to quickly send in a nomination, because a lot of times you get less than 2 weeks notice. Oh, here's an opening on such and such a committee. We also know that for every spot we get a nurse on, there's like 10 physicians. So we're competing against a lot of other groups, sometimes other disciplines, but we're very happy to welcome therapists and social workers and psychologists and everyone else who's part of the healthcare team, but we need more nurses represented. So the effort to do that is called the Nurses on Boards Coalition, and the goal being 10,000 nurses on boards by 2020. This is part of the Action Coalition work that spun off of the implementation planning for the Future of Nursing report. So this is a very active group. It's very formalized. They just hired an executive director. I just met her the other day. She'll be housed at ANA. And so we're very excited to see this work moving forward. You can go to that website, nursesonboardscoalition.org, and you can go in if you're already serving on a healthcare board, you can put that information in, or if you would like to serve on a healthcare board, you can enter your name. Well, leadership just doesn't come to us by osmosis. So ANA does have a leadership institute that offers lots of webinars and other opportunities for people to take advantage of programs, because we want to be able to have nurses across the country access tools if they aren't getting in the workplace or aren't currently in school, so that we can continue to make sure nurses are prepared to serve on boards. So what are we moving toward? Again, we've got this set of ideas that's at the end of our rainbow. As a country, we've said we believe in the triple aim, and that's been digested into 3 sound bites. One is better health, so better patient experience and better population health, better care, meaning better quality of care and outcomes, and lower costs. We also believe now, and this you may have been reading about some of this just in the last maybe 9 months, that the triple aim needs to be broadened to become the quadruple aim. The 4th aim being that we must take care of the care team, because we know that not only is the delivery of healthcare stressful, we know there are many demands, we know that there are also a lot of dangers in the workplace, and particularly nurses, 5th highest category of occupational injuries, leading to some kind of missed time. So we know that we need to take care of care providers. And one of the reasons is, if we're going to make the move from volume to value, we need nurses to really be there on all of our front lines, whatever the setting, because it is nurses that are truly making the difference. So we know that we want more quality, but we also know we have to reduce cost. So that is something that everybody in this room that raised their hand that's in an administrative role, and probably to another extent, probably it has touched everybody. That's been the mantra for years now. We've got to be able to figure out how to reduce our costs, but we want better quality. But one of the key activities that also came out of the Affordable Care Act was the Partnership for Patients. And the partnership really focused on 2 main things: reducing complications and reducing readmissions. So whether or not you knew you were participating in the Partnership for Patients, which was a public campaign to kind of sign on to do some of these things, here are the numbers that CMS collected after the project. From 2010 was the base year and 2013 was the ending year. So through the activities of our healthcare teams, over 2 million fewer hospital-acquired conditions, significant reduction in mortality, 87,000 lives saved, and significant savings. And it's nurses that made those things happen, absolutely, unequivocally. ANA's quality strategy covers many of the areas that I've touched on from the standpoint that, again, we need nurses at the decision-making tables. We collaborate and work with our partners across the country. It's important to work on the regulatory agenda in addition to the legislative agenda, because some of the regulatory changes can be even more sweeping than the legal ones, and they're easier to come by because you don't have to have Congress voting on them. We also know that the quality measures that are out there that are figuring out, again, what's the right care and how we get the right outcomes, have to be able to collect data about nursing. And so we're working vigorously on electronic quality measures and partnering for team-based measures for the future, and then obviously sharing best practices. Now, with all this work, you would say, wow, we're doing a great job. But the problem is, we still have terrible problems in quality. And the National Patient Safety Foundation has done a lot of work really looking at this issue, and they've equated the current death rate could be as many as 440,000 deaths a year that were preventable, which they've equated to 10 jumbo jets crashing every week. Now, as a nation, we would never tolerate one jumbo jet crashing every week, let alone 10. So we have significant room for improvement, and it means we cannot stop on our journey of improving quality. So one of the things that ANA has been doing for 2016, we've declared this year our year of the culture of safety, and our tagline is Safety 360, taking responsibility together, because we really believe nurses are the true leaders in terms of making the environment safe, not only for patients and families, but for caregivers, not just nurses, but the whole care team. Now, it's not easy. There's a lot of work to be done. And in a couple of these things, nurses are their own worst enemies. They work when they're tired. They work too many hours. They don't go get the moving and lifting equipment. You know, they're going to take a shortcut because they say they don't have time. And so we have to do an inward look, too, to say, what are the things that we should be fixing in order to make it safer and healthier for us in our own work environments. So this year, the theme for Nurses Week is going to be culture of safety. And in addition, you know, we've been doing webinars monthly, and we'll be doing the one in May that's free to all nurses on cultural congruence. And I raise that because that's somewhat new terminology. Many of us that learned about cultural competence or cultural sensitivity learned very specific things that were targeted to ethnic groups. Well, cultural congruence is a much broader term that says, you know, we have a commitment to society, and that means that and our code of ethics. We're not going to let people be disadvantaged or discriminated against for many conditions, whether it's their ethnicity or their religion or the color of their skin or the rituals they practice or their sexual preference or their gender, whatever the range of issues. Cultural congruence means we need to address all of those. And nurses are, again, some of the best individuals that can do that. So we have kind of a tall agenda to get over that rainbow. And as we think about kind of some of the pressing priorities, we've seen the horrific conditions that just led to indictments in Detroit with their water. We know we have an election coming up that's not been only entertaining but scary. We know that we now have this emphasis, none of you are scared, right? Okay. We now have this cancer moonshot, which again is the really high-tech, let's cure disease as opposed to, you know, let's try to figure out how we make the nation healthy. But we do have this going forward. We have the continued pressure on changing our reimbursement system. And we have so much data, we barely know what to do with it, although it continues to promise great results for us. So I want to stop, and for about 10 minutes, I'd like to ask you, what do you see the challenges as we're trying to get to this better future, our preferred future? Or what suggestions, bold or otherwise, do you have that you think we ought to be focusing on collectively in nursing and healthcare? So all of you shy people, come to the microphones, please. So we have 2 mics, one on each side. Would love to hear your comments or questions. Usually our students are first. Come on. Yes. Can you go to the mic, please? Thank you, Pat.
So mine's just a quick question, and that is, since nurses are the most respected by society, how do we get our voice better heard? Because it seems to me that's who patients would want to hear, right?
Right.
So how do we do that?
It's I think, an exercise for every single one of us in the room. What we need to make sure is that when we find that nurses are absent from decision-making groups, we have to insist a place at the table. We have to insert ourselves. We can't just shake our heads and say, oh, look, there's another group that doesn't have a nurse on it. So we have to get to those decision-making tables. The other thing is we need to purge from every nurse's language, I'm just a nurse. Okay, absolutely. We need to make sure that we are very proud and clear of what it is we've provided to that patient and family, and very clearly make sure we're introducing ourselves. I don't know what everybody's name badge looks like, but make sure that we have said, I am Pam, I am your registered nurse. Here's what I'm going to do for you. Here, and I'm sure all of our educators are teaching these things. but practice it. I mean, again, we learn some things, but then we get sloppy as we go into practice. We need to not be so busy that we don't go to interdisciplinary rounds or interprofessional rounds. We need to not be so busy that we say, I can't volunteer to be part of that really critical strategic committee. We have to be able to recognize that if we are absent, all of nursing's voice is absent. And again, we need to call groups out and say, you must have forgotten to have a nurse. Let me give you a name. Or, I'm willing to come on Tuesday, whatever that is. And that's in our work settings, it's in our community leadership opportunities, and it's all the way up the chain with your legislators. Go visit your legislators. They don't know anything about healthcare unless they happen to be a healthcare professional. You're the expert. We always tell that to all the groups that come together across the state. We have, on average, 300 to 1,000 nursing students that come to the state legislative advocacy days. Just think if every one of those nurses, after they graduated, continued to do that once a year. Write an email, write a letter. People still do that. Go visit your elected officials and talk about nursing, because you can share more in a 10-minute conversation than they'll learn reading a newspaper or hearing something in the hallway. So we all have to be part of doing that. I mean, again, the professional organizations are already doing that with these appointments, and we are calling groups out and making sure that we've got networks set up to get nurses' names sent in for things. So again, there's multiple levels, but if everyone did it, we would have people saying, oh yeah, I have to have a nurse. Because once there's a nurse present and they hear your contributions, they will continue to include you. Yes.
Hi, I'm a student at the College of Nursing, and I just had a question regarding, so the future nursing shortage, we're expecting to be short of about 1 million nurses, and I was wondering if there is a conversation yet open on the table of the difference between the selective process of letting potential nursing students into schools across the country and how many are graduating. So, for example, we have so many students, freshmen in college that wanted to be nursing students and don't make it into the program throughout the schools in Kentucky that could make great potential nurses, but we have this shortage. I just wanted to know if there was a conversation yet open on the table regarding that.
Yeah, thank you. There actually has been a long-standing conversation, and every year we see the number come out, and it's usually around 30,000 qualified applicants were denied admission to nursing schools. Unfortunately, that's happening for a couple different reasons. One is just the capacity of many schools. So it's either they don't have physical space, they don't have clinical placement space, they don't have the funds to hire more faculty. It could be all of the above. And so we know that, or it could be that faculty are retiring, which we know the average faculty member is about 8 years older than the average clinical nurse. So the faculty retirements are preceding the clinical workforce retirements, which is creating shortages. And one of the reasons it's so much harder to replace those faculty is that we didn't have a cadre of master's or doctorally prepared nurses ready to step into those roles. So the trajectory to get from 2-year degree or even a 4-year degree to be ready to take on a full-time faculty role is a longer period of time. So schools are adapting. There's lots of collaborations with part-time faculty in order to bridge those kinds of gaps. But we haven't completely figured out how do we get more space in general. I mean, again, I think each school is looking at what can they do. I think that one of the biggest challenges is that we still have a mismatch in what the professional groups think the country needs in terms of making sure we are advancing the baccalaureate and higher degree programs and making it easy for the individuals that have completed or are in 2-year programs to be able to articulate into the completing their bachelor's degree. So we have a lot of issues that are competing right now. 34% of all of the nurses graduating from BSN programs are actually registered nurses. So a third of those spots are in programs that do RN to BSN. So we have a couple things that we need to tend to, again, across our industry. And I don't have all the answers. I mean, again, I'm very willing to partner with all of my academic colleagues who are leaders. But it is unfortunate because we really want to be able to produce enough nurses to meet that future demand. I believe there will be a shortage that affects more than just pocketed communities in about 5 years. Yeah, thanks.
My name's Judy Niblett. I'm a nurse manager, and one of the greatest challenges I think we're faced with, especially managers, is that we have a very young group of nurses. We're growing so fast, we're expanding, and a lot of our nurses are going into advanced practice degrees and leaving, and we don't have that many clinical experts in the unit yet. Have you seen this problem in other areas, and what's their plan?
Yeah, thanks, Judy. I had that conversation with some of your director colleagues over a meeting earlier today. And I do think this is a problem that is primarily located in our academic medical centers with really good schools of nursing or colleges of nursing, which is, it's a very attractive career path to be able to get that minimum amount of clinical experience and then go back to school, because we've been saying, you know, one of the biggest areas of growth is going to be advanced practice nursing. And those jobs are very satisfying. They offer, again, a lot of opportunity. But the challenge is for you trying to maintain a stable staff, build that expertise so that at the bedside we continue to have the knowledge that goes from novice to expert. So one of the things that we talked about earlier was that we collectively need to figure out how do we return some of those nurses to the bedside. We have a history that has gone in the opposite direction, other than other professions. Other professions that have increased their educational requirements have actually kept people in the frontline jobs. Now, they again have their bumpy roads in terms of whether or not, you know, the doctorally prepared physical therapist is going to do a staff therapist job, or a PharmD prepared pharmacist wants to work in a retail location. So there are clearly maturation issues with those models. But unfortunately for many of us, the master's educated nurse in particular often moved away from direct bedside care, and the advanced practice nurses are typically in roles where they have a patient load that mirrors some of the medical care. So part of the challenge, I think, is to figure out how can we infuse those individuals with a different structured model, have nurse-led models of care that rely on those individuals to be the primary caregiver, not primary as in primary care, but be the main team member executing the plan of care and writing the orders and really orchestrating care for that team with staff nurses, so that we see the importance of that nursing expertise that goes far beyond what we think of as the shared medical care. So again, I think it's the academic medical centers that are going to need to resolve this, because you're having your own little brain drain while you're supporting the bigger goals of the profession. So it is a challenge. I don't have all the answers, but I think we'll need to equilibrate that. So I have to wish everybody good luck on that one. All right, so let me just take a minute and just kind of take a look again at where we're going. I think we do have enormous possibilities. Yes, we acknowledge that healthcare changes based on where the dollars go. We acknowledge we're moving from volume to value. We acknowledge that we will have workforce challenges. We acknowledge that nurses are truly the movers and the shakers in terms of improving quality. And I think what's most important, though, is for us to keep our eyes on that future, that we do want to have better education, more education for all nurses through all types of programs, formal programs and informal programs. We want to get nurses at those decision-making tables. We want full practice authority because that's what's going to put us on an equal footing. We want to be concerned about safety for the obvious reasons, but also when you talk the language of safety, that is a universal language. There is no unlevel playing field. Doesn't matter whether it's a physician talking safety or a nurse or a therapist or a financial person. Safety is universal, so that again positions us in a position of strength. So we have the tools, we have a growing set of educated nurses who can really take these issues and run with them. So I think the future is very bright. And I look forward to seeing many of you who are a lot younger than me taking the reins of leadership going forward. So I wish you all the best and thank you so much for having me. Thank you.
So I'm not going to let Pam slip away here yet because I just want her to know that this has really been a special day. It's just such an honor to know that we have the president of the American Nurses Association right here. Now, I can get away with this. Did you all notice all the great work that's being done through Pam's leadership at ANA, not once did she say anything about, let me see your membership card, okay? So as the Dean of Nursing, that's what it's about. This is really how we show our professionalism, that we have really optimized our professional identity, is claiming our professional home, and that is the ANA. And many of us are members in so many specialty nursing organizations, but this is the mega, this is the mother, this is our voice. And I tell you, I've been in nursing for 40 years, and I joined ANA right after I earned my baccalaureate degree. And many of you know I started as associate degree, and I didn't really get the nursing professionalism piece and the importance of having a professional home. There has never been a more powerful president than what we've got right now. And I don't just say that because we are UVA, okay? And where's our photographer? Because I've got to capture this moment. And we did not stage this, honestly.
Orange and blue.
That is the color of UVA. We did not stage it, really. But it turned out pretty neat. But Pam is so, yes, I'm calling my photographer because I got to get this Kodak moment right here. So you heard this. She walks the talk. People listen when Pam Cipriano is at the table, and she's encouraging us to be at the table. She's an academic, she's a clinician, she's a researcher, and oh my gosh, is she a scholar. And she is the ultimate leader for our American Nursing Association, and I'm just so proud you're here.
Well, thank you, Jamie.
So,
thank you so much.
Yeah, stand it up, stand it up.
Thank you. That's really sweet.
Thank you, guys. So we're going to have our Kodak moment, and then I really want to invite you all to go to the reception area by the piano. And, Dr. Cipriano wants to meet you, and we're going to have to tell her about Kentucky and our new governor and what may be happening with Medicaid expansion and a few other things. So she'll want to hear about our Kentucky politics. So please join us at the reception. Thank you, guys. We